I just wanted to start by saying thank you for joining us for our Brown Bag Lunch webinar, What HIV Providers Need to Know About Hepatitis C. We're really excited today to be partnering with Project Inform in San Francisco, especially given the new advances in Hep C treatment and the attention that hepatitis C has been getting in the public health field. So we're going to go ahead and get started. So I'll give you a little or brief introduction to our presenter for today. His name is Andrew Reynolds, and he is a Hepatitis C Education Manager at Project Inform. And in this capacity, he writes fact sheets and booklets on hepatitis C, HIV and HCV Co-Infection and harm reduction. He is also a counselor on the National Hepatitis C phone line, and the number is available right there for you if you need it. And facilitates several HCV support groups in San Francisco. He is a member of the National Viral Hepatitis Roundtable Policy Committee and the former chair of the San Francisco Hepatitis C Task Force. Prior to working for Project Inform, Andrew worked for the San Francisco Department of Health in HIV and STD prevention and treatment. And so we're going to turn it over to Andrew in a little bit. Just some ground rules before we get started. If you need to ask questions during his presentation, please use the questions function that should be in the panel to your right. And if you're having any visual or audio difficulties, please close out of GoToWebinar altogether and try logging in again. Last time we had a webinar, a few folks had some difficulty seeing the slides, but we found that if you close it and restart it, those problems go away. So without further ado, I will turn it over to Andrew.
Okay, thanks very much, Rebecca. And thanks very much for inviting me to talk about hepatitis C. Like Rebecca said, this is a really, really exciting time in hepatitis C treatment, and it's only getting better. The medications that are out now have higher cure rates than ever with shorter durations of treatment, fewer side effects, they're easier to take, and by the end of this year we're going to have probably 3, maybe 4 new drugs to choose from. And then by the end of 2015, it's going to be a whole new ballgame. We're going to have, I don't know, 10, 12 different potential regimens that we'll be able to pick and choose from. And, you know, for somebody who's worked in hepatitis C for a very long time, we had nothing until about 2011. It was, you know, literally a flip of a coin to get cured. And now I can seriously say that we can wipe out hepatitis C, not just in the United States, but worldwide in my lifetime. And that's a great way to be put out of work. I'll have to find another disease, but yeah, this is really good stuff. So today's talk, we've got about an hour, and I'm going to try to kind of roll through the slides, you know, relatively quickly, so there's plenty of time for questions and answers, because I think that's where a lot of the really rich discussion can happen. I hope to hit on all of the main points that you all are interested in. Honestly, you could do an hour on Hep C treatment. You can do an hour on Hep C and drug use. You can do an hour on sexual transmission of Hep C. So I kind of picked and choose and did sort of like a greatest hits of Hep C. And again, if there are questions, I'm more than ready to talk about them. We'll do a talk about hepatitis C. It says an intro to hepatitis C, and we'll do that kind of throughout the talk. A discussion of hepatitis C in African Americans and health disparities. Some tips for living well with hepatitis C, and that includes preventing Hep C, some stuff on HIV and Hep C co-infection. A real brief overview of treatment. Enough to kind of whet your appetite, but certainly more can be done. And like I said, by this time next year, it's going to be amazing. And then a discussion of advocacy and things that can be done and that need to be done, because while the treatments are wonderful, we've done a lousy job of testing people. Not enough people know about their hepatitis C status. And then once they do know about their hepatitis C status, we're now facing a significant challenge of access and linkage to care and paying for treatment. So the science is there. Now we got to move to really getting people aware of their Hep C status and then getting the treatments inside of them. Okay, so we can do the next slide. Brief history of hepatitis C. It's relatively new, I mean, in terms of our discovery. The earliest blood samples were found in frozen blood samples from U.S. military veterans as far as 1948. It probably goes back farther than that. We just don't have it. We didn't know what it was for a very long time, and it was called non-A, non-B. We knew what A was, we knew what Hep B was, but there was this other weird virus that was clearly causing inflammation of the liver. They didn't know what it was, so non-A, non-B. And in 1989, it was identified as its own unique virus. For the record, I believe we're now up to hepatitis E. There may be a hepatitis F, but that's fairly controversial. They figured out how to screen for antibodies in 1990, but it wasn't until July of 1992 that hepatitis C was fully screened in blood. And that's going to become a really important piece as we talk about risk factors and who should be screened for hepatitis C. Next slide. Really broad epidemiology, and the truth of the matter is our knowledge of Hep C epidemiology is fairly poor. Overall, upwards of 180 million people have it, about 3% of the world's population. All continents are impacted with relatively high rates of hepatitis C by comparison to other diseases. In the United States, it's the most common bloodborne infection. The numbers of new infections are really hard to get. We have terrible hepatitis C surveillance, and so we don't collect data on hepatitis C the way we have more robust surveillance for HIV and other STDs and other medical conditions. But, you know, 30,000 new infections per year. It's probably double that, if not more, upwards to 55,000. The official statistics for hepatitis C are about 2.7 to 4 million people living with it. The reality is it's probably more than that. Some people think it's as high as 6 to 8 million. And I'll give you a quick reason why we're a little bit unsure about our Hep C status. It is a reportable disease, but there's no funding for public health departments and public health labs to really do robust Hep C surveillance. So there isn't sort of checks and balances to do it. The way that we get our Hep C data is through a phone call. There is every couple of years a survey that's done where they call people and they ask them about their hepatitis status and other risk factors. Well, you can imagine how limiting that is. If I am using drugs and I get an anonymous phone call from somebody from the government, I'm certainly not going to say, oh yeah, stranger, I'm an injection drug user and I have hepatitis C. So there's a limit there. But the greatest limit is we're only reaching people who have phones. So we're not reaching out to the populations that are at greatest risk of hepatitis C. People in prison. In some states, 42% of prisoners have hepatitis C. Overall, if we, the impact of Hep C in prisons is through the roof. We don't reach out to homeless. We don't reach out to other institutionalized individuals. So our knowledge of Hep C isn't very good in terms of overall numbers. And it's co-infection. We know a little bit more, probably upwards of 400,000 people are co-infected. A lot of them are people who have injected drugs, but there is I would say by now, consensus that HIV-infected individuals are greater risk of sexual transmission of hepatitis C than HIV-negative folks. And so we'll talk about that in a little bit of detail because I think it's a really, really important piece. If you're working with people with HIV, talking to them about sexual transmission of Hep C and routine screening for hepatitis C is very important. Okay, next slide. So real briefly, the liver is the largest internal organ. It has over 500 vital functions. The most important, well, they're all important, obviously, but you know, the liver is your filter. So everything we take into our body, everything we eat, breathe, drink, absorb through the skin, goes through the liver. And so when the liver is damaged, a lot of symptoms and side effects happen as a consequence. You know, for most folks, provided that the damage hasn't gotten too severe, cure of hepatitis C results in a remarkable improvement in quality of life across the board. So when you start to read some of the articles, particularly these days, where people are questioning the efficacy of the new treatments, mainly because they're so expensive, and they're not sure if curing somebody of hepatitis C actually has long-term benefits, all you got to do is talk to somebody who's been cured, and they'll tell you their life is much, much better. And then really briefly, hepatitis is simply means inflammation of the liver. Hepa is the liver. Itis is inflammation. There's any number of things that can cause hepatitis. If I drink too much tonight, tomorrow morning I could have alcohol-induced hepatitis. If I take too much Tylenol, I could have Tylenol-induced hepatitis. Today we're going to talk about viral hepatitis, and specifically hepatitis C. Next slide. All right, so there's the liver, and it wasn't until, I don't know, the night before last when I realized I had nothing about liver and liver damage in a Hep C presentation. But that's essentially what the liver looks like, and there's actually another stage, stage 0, and that's where you have no damage at all. Slowly but surely over time, Hep C does damage to the liver, and I mean slowly. 20, 30, 40 years for individuals who are HIV negative. If you're HIV positive, it speeds up, almost double to the risk of developing cirrhosis. Drinking alcohol on top of hepatitis C will also speed up liver damage. But in the absence of HIV and the absence of booze, Hep C is a relatively slow-moving disease, and it behooves us to treat people earlier to prevent further damage from happening. But even a person who's been living with it for 30 years, if they're in stage 2, even stage 3, the opportunities for treatment and cure are really quite good. And as the first bullet down there says, treatment can slow, halt, or reverse liver damage in stages 1 to 3. The liver is a pretty remarkable organ that can regenerate. It's the only organ that we have that can regenerate, and it doesn't always reverse, but you know, in a lot of folks, they get cured, and slowly but surely over time, their liver gets back to being fully functioning. So it's really really quite remarkable. We'll do the next slide. All right, so Hep C transmission. The main way Hep C is transmitted is blood-to-blood contact. And when we say blood-to-blood contact, you know, people really, on the phone line, I get calls about this all the time. People really freak out like, oh, I had a cut on my hand and I touched a doorknob where somebody who had a bloody nose touched it. That's one of those things where blood-to-blood sort of makes us think that every sort of risk is equal. But the reality is, when we say blood-to-blood contact, we're really talking about sort of amongst people who inject drugs, where I'm pushing somebody else's blood directly into my veins. Intranasal drug use, you know, if somebody's got blood on the tip of a straw and I share that straw, put it in my nose, there's risk of transmission there. If I have bleeding lips and I'm sharing a crack pipe and that person has hepatitis C, I could get it that way. So it's more of a direct blood-to-blood contact. Other ways are theoretically risky, but I think the reality is it's not likely to happen. Mother-to-child transmission does occur it's actually slightly less than 5. We used to think it was 5 and 10. It's probably between 3 and 4% of women with hepatitis C will transmit the virus to their baby. There's no way to prevent that from happening. There isn't sort of like a mother-to-child prevention the way we have for HIV. But what often happens is the baby is born and might test positive initially, but you wait a period of time, actually about 1.5 years, and a lot of babies clear the virus because they've just had sort of like the antibodies from the mother, so they weren't actually infected. Mother-to-child transmission is more common if the mother is co-infected. Goes up to about 20%. Next slide. So here it is, you know, the population today that has the greatest burden of hepatitis C are people who inject drugs. And when you look at the rates of new infection, the Hep C prevalence, it's between 30 and 70%. In some areas, it's even higher. I'm sorry, prevalence is overall rates amongst injection drug users. I flipped that slide around. I'm going on automatic pilot. Incidence is new infections, and so amongst people who inject drugs, it's between 16 and 42% a year. Again, in some areas, it might even be a little bit higher. Overall, and this is probably an underestimation, about 56% of Hep C infections in the U.S. is due to injection drug use. It might have just been a one-timer, you know, in the 1960s. You were at a party and boom, you tried it. Or it could be somebody who, you know, uses injection drugs regularly. The CDC estimates that injection drug use accounts for at least 50% of acute infections. It's most likely much, much higher than that. Again, our surveillance is not so good. And this actually is not complete. HIV Hep C co-infection. If you got HIV from injecting drugs, it's almost a given that you have hepatitis C. I didn't write it down, but it's something like 90% of people who got HIV from injection drug use are co-infected with hepatitis C. Okay, next slide. So these are all the ways that blood could get introduced into the injecting process. And Hep C is a really tough virus, much tougher than HIV. And the next set of slides will kind of go into a lot of detail, but I think it's really important. So I wrote a lot more than I normally would. But this is a really key piece, because I really feel like syringe exchange, if you have access to syringe exchange, and not many people do, but in the United States, if you have access to syringe exchange has done a really good job of preventing HIV amongst people who inject drugs, because they're not sharing syringes. But Hep C can live in cotton. It can live in rinse water. It can live on the alcohol wipe, on the ties, wherever, and in cookers. And it can live for a longer stretch of time under a variety of different conditions than HIV can. So even if you've never shared a syringe, while you're doing great HIV prevention for doing that, if somebody is sharing cookers, cotton, or water, which is extremely common, then the risk for hepatitis C remains relatively high. Okay, next slide. So here's some examples. In the syringe, Hep C can survive in the barrel of a syringe for up to 63 days. That's really quite remarkable. The amount sort of increases the infectivity. Soil load, which is such a creepy term, but that's what refers to sort of what's left in the syringe, blood and other kind of organic material. The more blood there is, the greater the risk is. And that's where these next two bullets come into play. So there are two types of syringes, high dead space syringes and low dead space syringes. And if a high dead space syringe, it carries so much more blood that the risk of transmission in those types of syringes are greater than in low density syringes. And so if you have a syringe exchange in your area, that's actually something to check out. You know, go visit and see what type of syringes that they are handing out. It varies. So a lot of places have a variety of options. But if you talk to a person about using a low density syringe, that's harm reduction, and that reduces their risk of hepatitis C. And then there's just an example. I mean, you know, it's much more common to get hepatitis C from a contaminated syringe than it is for HIV. Next slide. Now the cooker. And I should say, Hep C's lifespan on surfaces is a bit of a moving target. It seems like the more we study it, the longer it goes. So the most recent sort of research that actually looked at Hep C on drug injecting equipment shows that Hep C can survive for infectious levels for as long as 16 days, over 2 weeks. In medical settings, it's actually been found to live even longer on surfaces. We don't know how that's going to translate into like us in the community, but it'll be very interesting to see if they research, well, if it can live up to 6 weeks in a hospital setting, let's check out, drug use settings like, shooting galleries or the tops of bio buckets, various things, and to kind of get a sense of how long it lives. Hep C is remarkably tough, and it can even live under pretty hostile heat conditions. If somebody is cooking their heroin, they're going to kill HIV really quickly, 7 to 10 seconds. But for Hep C, you've got to go for like up to 1.5 minutes at a really high degree, 136 to 144 degrees. And as that last bullet shows, nobody does that. And in fact, if you did that, you'd mess up your dope. So, Hep C is almost like, a perfect storm for infection amongst injection drug users. Next slide. And the water. This one, when I first learned this, it blew me away. So Hep C can remain infectious in water for up to 21 days. The lower viral load, the less sort of, the more dilute it becomes, and so the water can kind of lose its infectivity. But Hep C viral loads can be really, really high, so that's not really something that we can quantify in the real world. But here's where this is what blew me away. So the container makes a difference, because a lot of people reuse water, or they dump out their used water, but they dipped into plastic water bottle, and they reuse the water that's in that bottle. Plastic sort of is porous enough that the hepatitis C can be absorbed into the plastic. So even if you dumped out that used water and replaced it with fresh water, that fresh water becomes infected with hepatitis C, contaminated with Hep C. And so it can transmit it that way. And the same thing happens with aluminum. It does not happen with glass containers. So if somebody is using a glass or a glass water bottle for their rinse, and they clean that out, then Hep C will not live in that setting. Okay, next slide. Here's a picture from a medical anthropologist, actually out of, I think, the University of Denver, Steve Kester, and he's been doing ethnographic work with injection drug users for a long time, and he's really like a pioneering researcher on the ways in which drug users share works, even when they never share a syringe. And like I said, we've done a great job on the syringe side of things. We need to boost up our distribution of drug injecting works and various supplies if we really want to have an impact on Hep C. Okay, next slide. So ways to prevent hepatitis C amongst people who inject drugs. Aseptic injection, that was sort of a tool, a message that they put out, I think like in Australia, if I remember correctly. And that's where they sort of treated injecting drug use the way you would treat, doing injections in medical settings. Use clean supplies each time you inject, and that includes everything, cotton, water, cookers. I didn't mention it in the slides. Hep C can live in a cotton filter for about 24 hours. If you wrap it up in foil, it can live for about another 24 hours. So if it's wrapped in foil, it can live for 48 hours total. And cotton shots are extremely common. Sharing cotton is a very common practice, and there's no way to disinfect cotton. It's just if Hep C's there, it's there. So ideally, using new supplies every time you inject. If you do have to split drugs, you and your friends have gone in to buy drugs, splitting them in a way that doesn't introduce blood is a really good practice. Front loading, back loading, that type of thing. Another way to help a person minimize their risk for hepatitis C is to move towards non-injection. It's not the drug that causes Hep C, but it's the sharing of works. And so if you're not putting a hole in your arm, pushing somebody else's blood inside of you, the risk goes down. There's still some risk, and we'll talk about that, but it's still a less risky way. Again, that's just sort of harm reduction. And then, if a person is Hep C negative and they're using substances, helping them quit using is, the ultimate way to prevent hepatitis C. If they're ready for drug treatment, help connect them to those services. If they're not, again, work with them in a harm reduction, non-judgmental way until they're ready to get there, or if they're ready to get there. If they're not ready to get there, do the above things to help keep them negative. Okay, next. So I'll kind of just real quick with this one. Bleach isn't necessarily a great way to kill hepatitis C. It'll kill HIV. 2 minutes of bleach will kill hepatitis B. Hep C appears to, the jury's out on bleach. I've read some things where it has said that bleach after 10 minutes will kill hepatitis C, but that also does a lot of damage to the plastic, so I wouldn't recommend bleach as a harm reduction tool for Hep C transmission. But if there's nothing else available, bleach the syringe, and then rinse like crazy. Tell the person to rinse with as much water as they can. A, because you want to get rid of all the bleach, to keep that toxic stuff out of you. But B, maybe, and this is just me, I don't know if this is actually true, you can sort of rinse out excess hepatitis C, particularly in those high density, high dead space syringes. And we'll do the next slide. So a quick piece on Hep C and crack use. I'm not sure where all of you guys are working, but I live in Oakland, but I work in San Francisco, and we've actually been pushing in San Francisco to get a crack pipe exchange going. There are a couple of really successful crack pipe distribution programs up in Canada, Toronto and Vancouver, and they've been remarkably successful in reducing bloodborne pathogens from that risk. So sharing of pipes can transmit hepatitis B and hepatitis C. It may transmit HIV, but I don't think it's that efficient. I think Hep C is a more common way that it can be transmitted. In fact, they've studied actual crack pipes, and they've looked for viruses on the stems after use, and Hep C does pop up, whereas HIV does not on the actual stem. Of course, the behaviors that we do during and after and even for crack might change, might increase some risk, but the actual pipe probably causes Hep C more than it would cause HIV. Covering the pipes with rubber stems, wood stems. Wood stems can get a little hot, but they're used sometimes. If there's nothing else, cleaning the pipe down with bleach or alcohol wipes, wiping it off with water will potentially minimize risk, not eliminate, but minimize. Helping a person keep their mouth healthy is a really big piece. If your agency can afford lip balm, having lip balm available. Making sure people stay hydrated so that they don't have cracked lips. Referrals to dental, the better their gums are, the less risk of blood-to-blood contact. And if it's possible, advocate for crack pipe exchange. That's going to be, I think, our next big harm reduction battle. Okay, next slide. So hepatitis C and alcohol, they do not go well together. I mean, alcohol alone can be very damaging to the liver. And when it comes to hepatitis C, alcohol is, literally fuel for the fire. It helps hepatitis C reproduce much, much more. And it increases liver damage. This first bullet, I wrestle with this bullet because certainly 50 grams or more per day accelerates disease progression. There's no question about that. But there's a lot of research to suggest that even minimal drinking over time increases the risk for the development of liver cancer. And so when it comes to hepatitis C and alcohol use, anything you can do to help a person get towards abstinence is the way to go. Even a casual glass of wine with dinner over time has been shown to have higher rates of liver cancer and development of cirrhosis. Women appear to be more impacted by alcohol use in their Hep C progression. And alcohol actually reduces the impact of Hep C treatment for a number of reasons. It increases the hepatitis C viral load, so that just makes it harder to treat. But they also think it sort of impacts the therapeutic, the way the drugs actually work. Next slide. And there's just a picture of sort of like a standard drink, and that's 10 grams of alcohol is in each of those. So 5 beers is an example of a problem drinking that will lead to Hep C. But again, 1 beer is probably not so good either. Okay, next slide. So those are all the things that I recently, I just kind of said. It definitely speeds up Hep C disease progression. Increased risk of chronic Hep C infection. We're going to get to diagnostics, but one of the things that happens is about 25% of people with Hep C clear the virus naturally within the first 6 months of infection. We don't know why. We wish we knew why, because maybe we could replicate that as a preventative tool, as a vaccine. But about 1 in 4 people will clear the virus. If you drink, that's less likely to happen. So if I get infected with Hep C today, maybe I'm going to clear the virus in the next 6 months. But if I'm drinking on top of today's infection, it's less likely that's going to happen, and I'm more likely to have hepatitis C for the rest of my life. So that's the big there. And then the increased risk of fibrosis, which is the beginnings of scarring, cirrhosis, the really severe scarring, and then all of that increases the risk of liver cancer. So like I said before, anything you can do to minimize alcohol use, if not eliminate alcohol use in the people you work with, would be a really good thing for folks. Okay, next slide. So here's sexual transmission of Hep C. It can be transmitted sexually. It just doesn't happen all that regularly. And the next bullet, it doesn't appear to be present in semen or vaginal fluids. If there's blood in semen or vaginal fluids, then it can be in there. But whenever they've studied it, it's been really kind of hard to isolate. And some studies have said yes, other studies have said no. It seems to be kind of intermittent. More common in HIV-infected folks than HIV-negative folks, but it's really not in sexual fluids. But blood can happen during sex. There's microscopic tears in the vaginal wall, tears during anal sex. So there could be some risk there. And there's any number of studies, but they've looked at sort of long-term studies of serodiscordant couples. One person has Hep C, the other person doesn't. Male, female, follow them over time. This is actually in heterosexual couples. And, the odds of Hep C transmission were really, really low. I've actually seen one meta-analysis where they took all the research of sexual transmission of Hep C in HIV-negative heterosexual couples, and it's something like 1 in 12 million were the odds. And so when I talk to people about sexual transmission, I say it happens. There's case studies that we can refer to where it happens. It's just not commonly transmitted. But if there's blood present with a sexual partner who has Hep C, it's definitely worth testing. If you don't know the person's status and their risk factors for Hep C are essentially none, it's probably nothing you need to worry about. But if you know there's Hep C, it's probably worth testing. But if not, the risk is super low. Next slide. Checking regularly for STDs is really big. There is a relationship between STDs that cause sores, herpes, primary syphilis, and Hep C transmission. Just kind of increases the risk of blood-to-blood contact. Obviously, talking to people about Hep C status is a way to sort of minimize the risk. If a person knows that they have it, you can do different things to prevent the risk. And just being cognizant of blood is probably the best message to put out to folks. If there's visible blood, then there's a risk of Hep C, if the person has Hep C. And so, making sure that a person kind of is aware of that is a nice message to put out there. Next slide. So this is where sexual transmission of Hep C is more common, and that's in individuals who are living with HIV. And we know more about gay men with HIV, MSM, than we do other populations. But when they've looked at risk of transmission, really HIV is the thing that matters, and this is regardless of sexual orientation, gay, straight, transgender, male, female. If you're HIV negative, the odds of Hep C transmission are really, really low in those populations. If you're HIV positive, it goes up. I probably should update this slide to say I don't think it's emerging evidence anymore. I think it's emerged. I think there's enough data in the United States. There's better data in Europe and Australia to show that HIV-infected folks have greater rates. These are folks who've never injected drugs or have other clear risk factors. And the sexual risk factors look to be condomless insertive receptive anal sex, top and bottom. The rates are relatively close. What is termed mucosally traumatic practices, and that includes fisting, vigorous sex toy play. Group sex actually is a identifying risk factor. Individuals who participate in group sex have higher rates of hepatitis C, and they've actually sort of studied the actual hepatitis C in sexual networks, so they can trace sort of how it's been transmitted, and they have found it within some relatively tight sexual networks, and that group sex was one of the risk factors in those networks. And then using non-injection drugs, particularly during sex, are risk factors for increased risk of Hep C. Okay, next slide. Okay, there's no vaccine, and this is important because a lot of people will tell you, oh, I don't got to worry about Hep C, I've been vaccinated. They've been vaccinated against A and B. So if when you're talking to folks, this is a message that you're going to hear quite a bit. So telling them that, oh, no, you haven't been vaccinated for Hep C, you've probably been vaccinated against A and B, is a really good piece. One of the things, well, let's do the next slide. Okay, so the way to screen for hepatitis C is actually complicated, and it's more complicated than HIV. So it is an antibody test, and there's actually a rapid test. Right now it's approved for finger stick or blood, not approved for oral. In Europe it's approved for oral. I assume they're going to try to approve it here in the States. I haven't seen anything lately. But you can get the results in 20 minutes. The trick is, well, there's two tricks. First is the window period, and it's not as clearly defined as with HIV. It can take up to 6 months. That's less common. Most people will develop antibodies within the first 3 months of infection, and an even greater percentage happens relatively quickly. But generally, if you're negative at 3 months, they can be very confident that they're negative, but they really would want to do a follow-up when they're 6 months out from their last initial Hep C exposure. The real trick with Hep C is you can test antibody positive, but actually not have the virus. like I mentioned earlier, about 25% of people clear the virus within 6 months. So if my risk was 2 months ago and I'm antibody positive, and then they confirm that with a viral load, and I've got virus in my body, they're going to follow up with me in 4 months, 6 months out from my risk. If 4 months from now, my antibody test will stay positive, but my viral load is negative, then I'm one of those folks who cleared the virus. I'm going to test antibody positive for the rest of my life, but I'm not going to have actual virus in my body doing damage to my liver. This is a huge message to get out to folks because it's really poorly understood. And doctors are actually often making an error in the way that they diagnose folks. So they'll test somebody for antibodies. That antibody test is positive. Oh, you've got hepatitis C. And you're on your way. When the reality is they need to confirm the test. CDC did a study at the end of last year. About 50% of people with positive antibody tests had no record of a positive viral load test. And I get this all the time on the phone line. People calling saying, oh yeah, my doc said I tested positive. I do some investigating, they didn't get a viral load. I tell them to go back to their doc, they get a viral load, that viral load is negative, they don't have hepatitis C. Happens a lot. So making sure you talk to folks about getting that confirmatory test is important. And then the final thing that I didn't put in the slide and I should have is Hep C, unlike other hepatitis is the plural of hepatitis, is you can get it back. So again, I'm one of those 25% of people who cleared the virus, but next year I shared a syringe with a person who has Hep C, I can get reinfected. And this time it can stay and I can become chronic. And I think this happens a lot. I think people get it, clear it, get it, clear it, get it, keep it. Because of our poor messaging for Hep C testing. This also happens for individuals who have been cured. So if I was chronically infected with Hep C and I take the meds and I get cured and I share syringes later, I can get reinfected. So talking to folks about reinfection and routine testing is very, very important. Okay, next slide. All right, we'll whip through this. So there's two distinct populations who should be screened for Hep C. The first these are called the birth cohort, the so-called baby boomer guidelines. If a person was born between 1945 and 1965, they should get a one-time antibody test. This population is disproportionately impacted from hepatitis C. They had risk factors, you know, they used drugs and did other things, but also a lot of people got exposed from, you know, medical settings because we didn't know about it. So the CDC did a study and they found that if everybody got tested with Hep C, we would uncover like 800,000 previously unknown infections and potentially reduce deaths by like 121,000. I mean, it was really phenomenal. And so this is actually a recommended screen. Whenever the USPSTF gives a screening recommendation a good score, a score of A or B, then that means it doesn't cost people a dime under health insurance. They can get the test for free. That's a benefit of the Affordable Care Act. The next population that should be tested are individuals who are at risk for Hep C. And there's a listing on the next slide that has all of the potential risk factors that the USPSTF has identified. There isn't a clear sort of, like, how often should somebody test? Should it be every 3 months, every 6 months, every year? Sort of done on a case-by-case basis. And you know, if I'm an active injection drug user, it probably makes sense to screen me more regularly than, obviously, if I had a blood transfusion in 1991 and no other risk factors. If I'm negative, you don't got to test me again. But these are all the risk factors. Notice in the second bullet, intranasal drug use from snorting straws. So that's definitely in there through the USPSTF. They did not address sharing of crack pipes or crystal meth pipes, but I think that's a significant enough risk factor that individuals who do that should be screened regularly as well. Okay, next slide. If somebody has hepatitis C, things that they can do to live healthy, definitely want to make sure that they've been vaccinated against Hep A and Hep B. Make sure that they're responsible for minimizing household transmission. Hep C is not routinely transmitted in household settings. I mean, I could share a fork with somebody, I could drink out of a cup with somebody, I'm not going to get it. But if I share a razor, if I share a toothbrush, there's greater risk there. So making sure that that doesn't happen. And then the same thing goes for injection drug use. If I've got Hep C, I'm going to make sure that I do everything I can to not share with folks. Reducing or stopping alcohol is big. Quitting smoking is big. Smoking is just bad overall for our health, but it's particularly bad for individuals with Hep C. And then make sure you're doing regular checks. A lot of people aren't doing Hep C treatment right now by choice or different circumstances. But if you're routinely checking your liver because it's such a slow-moving disease, you got time. But just make sure you're regularly checking so something doesn't sneak up on you. Next slide. Eating a healthy, balanced diet is good. A diet doesn't have as much of an impact on Hep C as one might think, but it's still important. One of the things that Hep C does is it does control fats in the bloodstream, and so individuals with Hep C might have higher rates of cholesterol. So, doing a healthy, low cholesterol diet is a really nice piece. No shellfish. Shellfish could have viruses in them that can be really damaging to the liver. No raw fish either, so if somebody is really into sushi with Hep C, they should stay away from that. If they're going to take a vitamin supplement, try to get one that doesn't have iron in it. Too much iron can be damaging to the liver. There are some herbs that people take that the jury's out as to how effective they are on the liver, but still people take them, milk thistle, for example. Make sure that if anything that a person is taking, they're talking to their medical provider about it, because some of these herbs can have interactions with other drugs that they're taking. Next slide. Too much acetaminophen, too much Tylenol is really hard on the liver. It's actually, Tylenol overdose is actually one of the leading causes of liver transplants in the United States. It's safer in small doses, but always check, make sure your clients are checking with their providers around taking it. Never mix it with alcohol. That just becomes really bad. And then, acetaminophen is in a lot of different medicines. So even if a person thinks that they're not taking too much, if they're popping a couple of Tylenol for a headache, taking some other, medicines for chronic pain, taking some cold medicine, that can all sort of contain acetaminophen, which leads to the dosage can kind of sneak up on a person and accidentally cause damage. So making sure that they're aware of acetaminophen in all of their medications. Next slide. So HIV and Hep C co-infection, a significant problem in the United States, worldwide, but the United States. Hep C damage speeds up in the presence of HIV. Hep C may have an impact on HIV, but it's not as dramatic as the way HIV has impact on Hep C. The healthier the person's immune system, the slower Hep C disease progression is. So a person taking care of HIV is actually a way of taking care of their hepatitis C. If they have a high T cell count, no viral load, doing well that way, that's liver damage. Most Hep C medications pass through the liver, so there can be some challenges. There are certain meds that maybe a doc would avoid, but for the most part, the HIV meds are healthy to take. Next slide. So if you've got a client with co-infection, make sure they're monitoring their Hep C pretty regularly, every 3 to 6 months. Treating HIV goes a long way towards keeping the liver healthy. If a person is on HIV and Hep C treatment, they've got to be aware of drug interactions. Some of the newer drugs have fewer interactions, so it's going to be a really sort of great time to treat HIV and co-infected folks, so that a person who's treating the patient is really comfortable with HIV and Hep C. And then obviously offering them the support and things that you would normally do is extremely important. Next slide. All right, so we'll go through the meds real quick, and then I want to open it up for questions. The rest of the stuff you can read pretty clearly. So treatments, up until 2011, it was interferon and ribavirin. So you did a shot once a week, you took pills daily. And depending upon the type of hepatitis C that you had about a 50% chance of getting cured with terrible side effects, and you took these meds for a year. The ultimate goal is to do all pills, all oral pills, for 12 weeks and possibly less without having to do interferon. And really, I think we're going to move towards getting rid of ribavirin as well. We're not there yet, but we're real close. The most recent drugs approved, Sovaldi, the generic name is Sivosbuvir, made by Gilead. That actually did get FDA approved to treat genotype 2 and 3 without interferon. A quick word on genotype. Worldwide, there are 11 different genotypes for hepatitis C. Really, 1 through 6 are the most common. In the United States, 1 through 4. 1 has always been the most difficult one to treat, but these new medications actually work against genotype 1 really, really well. And then 2 and 3 and 4 are also treated with these new meds. That last bullet, there is another drug that was approved at the end of 2013 called Olysio. Its generic name is Simeprevir, made by a drug company called Janssen. Although this regimen isn't FDA approved, it's been studied. The study is called the Cosmos study. And a person could take Sovaldi and Olysio, which is 1 pill each once per day, with or without ribavirin, for 12 weeks, no interferon. And it had remarkably high cure, the mid-90 percentiles, up to the mid-90 percentiles. And this is sort of like our first snapshot into what the future of Hep C treatment will be. And that's our next slide. Actually, this is an example of the recommended treatments from the American Association for the Study of Liver Diseases. They just put out a guidelines for testing, treating, and managing Hep C. And these are the recommended regimens for each genotype. There are alternative regimens and then regimens that are not to be used, listed in that guide. Okay, next page. So here we go. By the end of this year, we've got 3 new drugs for sure. So this AbbVie is another drug company, the 3D drug combo. It's all oral pills, 3 different drugs, so it kind of attacks Hep C the same way HIV sort of, you take different classes of drugs. And it has shown remarkable results in people with genotype 1. It's not used for other genotypes, but there are other better options for genotype 2, 3, and 4. But for genotype 1, you're looking at 12 weeks of pills, 96% cure rate, minimal side effects. Really easy for people to take. Also at the end of this year, this combination, Ledipasvir plus Sivosbuvir, this will be made by Gilead. It's to treat genotype 1. It's a single pill. So this is 1 pill once per day, as opposed to AbbVie, which was a couple of pills. It had remarkable results, 93 to 99%, for some people as short as 8 weeks. So this is going to be a significant game changer. And it's also been shown to work really, really well in co-infected folks. I don't know if it's going to get approved for co-infected folks, but it's there. And then finally, at the end of this year, is Decladisvir, which is made by a drug company called BMS. It's a really good drug used in combination with other drugs. So Sivosbuvir and Decladisvir work really, really well together, including for people who are really hard to treat. So I think what's going to happen is docs are going to sort of pick and choose. They're going to say, okay, you're going to get Decladisvir, Sivosbuvir, and then you over there, you're going to get Ledipasvir, Sivosbuvir. You've got genotype 1. I'm going to give you the AbbVie combination. Like they're going to mix it around, and we're going to see some just remarkable results as we get to procure. Okay, next slide. Hep C is a significant issue in the African American community. 3% of African Americans are infected with hepatitis C, so twice as many when you compare it to Caucasians and Latinos. When you look at when we look at those numbers of the 4 million people officially with hepatitis C. Nearly 23% of those 4 million people are African American. It's a significant issue. Next slide. And I gave some reasons as to why, but I want to open up for some questions. And then I'll just very quickly, my email and phone number are at the beginning. We'll email out this presentation to you all, and I'll email a link to the AASLD guidelines and to our national Hep C phone line, so that way you have it. Please call me or email me about this, if particularly when you're doing your projects and other things. I would be more than willing to talk with anybody about hepatitis C further. But anyway, it's 11 o'clock. I can stop for a couple minutes if you can.
Yes, so if you need to get off for something else, please feel free, and we'll send out the recording so that you can listen in on the questions later on, and we'll also send out the slides to you in an email. But if you can stay on for another 5 to 7 minutes, please do so. So we'll open it up for questions now. I do have 2 questions that came in via email, so I'll go ahead and start with those, and then if you do have any further questions, please use the question box or raise your hand, and I'll unmute you so that you can ask. So the first question that we have came in from Linda Stringfellow from Mississippi, and her question was, what are the top 3 things that we should make sure we emphasize during our presentation to people in the community and to other CBOs?
Ooh, top 3. Well, I think the first one is explaining the meaning of Hep C testing. So, letting them know that a positive antibody test is not an automatic guarantee that you're chronically infected, and that follow-up confirmatory testing is essential. And this is going to sound terrible. I hope there are no doctors on the phone. Just because a doc says they confirmed it doesn't mean that they have. There's too many examples of doctors who have tested antibody positive and not done the confirmatory test. So, make sure that your client has a copy of their lab results so that they can see positive antibody test, negative viral load, or positive antibody test, positive viral load, I'm chronically infected. So that would be number 1, understanding the meaning of hepatitis C testing. Number 2, reinfection. And I think this is going to become a big piece, particularly for individuals living with HIV, because of the sexual transmission piece. But letting a person know that if they've cleared the virus, either naturally or through cure, they're at risk for reinfection. And being aware of that is important, and testing routinely is big. And then the third one, if somebody is living with hepatitis C, doing anything and everything they can to eliminate alcohol from their lives, and being able to support a person around that, I think is very, very important. So those would be the 3.
Okay, thank you, Andrew. I think that was very helpful. The second question that we had that came in earlier from Shannon Tillett is, what are the most common side effects experienced from someone with HIV and Hep C co-infection?
So Hep C, if Hep C had symptoms, I think more people would test and we would know more about it. The problem is, the Hep C is called the silent epidemic, and it's called the silent epidemic because there aren't symptoms. I've read where something like 30% of people with Hep C kind of go back and say, oh yeah, I had these symptoms. But that's only when you're first infected. So maybe you're going to feel like you have a flu, joint aches, fevers, nausea, diarrhea can sometimes happen. Clay-colored stools is a symptom of acute infection. Some people might get jaundice, the yellowing of the eyes, the yellowing of the skin, but that's really rare. But the reality is most folks don't have symptoms when they first test positive. And then they're living with it for 20, 30, 40 years, and they don't have symptoms. It's just a really slow, sneaky disease. And then when it becomes sort of more serious as the cirrhosis gets more severe. Then you start to get, the water retention, the mental confusion, the jaundice, things like that. So symptoms are tough. I'll include a fact sheet on signs and symptoms, but the message that I put out to folks is don't go by symptoms. Symptoms aren't going to tell you if you have hepatitis C. Symptoms aren't going to tell you the rate of damage that's happening to your liver. And a lot of times the symptoms that we have are from something else entirely. My flu-like symptoms are the consequence of the flu, not because I got tested positive. The only way to know how your liver is doing is through testing, and that's either to do the antibody test to find out if you've got it, followed by the confirmatory test, and then regular liver function tests, ultrasounds. There are other tests that they can do to just, check the health of the liver.
Okay, great. Thank you, Andrew. It doesn't look like we have any other questions coming in. So I'll go ahead and move on to our announcement section. This should be very, very, very brief. Thank you all for staying on. Pretty much everybody stayed on the line, so I'll be quick with this. So after I end the webinar today, please take the survey. It will launch right after the webinar ends. And then if you do plan on doing a brown bag lunch event in your community, please submit the event information form by next Thursday so that we can get that flyer to you so that you can start promoting your event. Also, the USCA winners will be announced Friday, June 13th. So please, if you haven't submitted all your documents up until now from the beginning of the year, in terms of brown bag lunch programs that you have hosted, please submit those also by Thursday of next week so that I can make sure that all your stuff is accounted for. And then finally, our Science and Treatment College fellowship applications are open, and the deadline is approaching very quickly. So please, if you're interested in applying for our year-long fellowship, which is a partnership with UCLA, which will be, immersed in the science and treatment of HIV and really building your capacity and your organization's capacity to provide services. If you're interested in that, please email programs@blackaids.org, or you can find the application materials online at blackaids.org, and then go into the Programs tab, the AHU tab, Science and Treatment tab, and then Becoming a Fellow. And then you can download all the materials and then submit them to programs@blackaids.org. And since we have no other questions, I'm going to close up, and you'll be receiving an email from me later on today with the slides and the event information forms for you to submit. So once again, I just want to thank you so much to Andrew and Project Inform for partnering with us. I think we learned a lot from this webinar, and hopefully our brown bag lunch leaders were able to relay this information to their communities so that more people are aware about HCV testing and the new treatments that are available. So thank you, Andrew, and we'll speak to you soon.
Oh, thanks so much. This was fun.